perf, it will seal it open. Now here is where we changed course, and these are some of our publications. 2 of them are coming out in press. When other interventions are employed, and when you pull the stent out, or you needle knife, the area looks open. Why do we fail? Why do they develop restrictures? We were trying to figure that out. So what we do in our practice is after this, any intervention is performed, we go back to weekly dilations. Remember, our guy failed weekly dilations protocol. 33% respond. Our guy failed. After other interventions, we immediately go back so that we don't lose out on the gains we made after stretching the stricture. And then with this approach, what was found that from 33%, when we went back to weekly dilations after other interventions, we reached almost 60% success rate. Now, what is interesting is that these patients were sent to us from outside hospitals as failed dilations. But what if you can predict at index endoscopy that this stricture is going to be refractory? First time you go in, you can make a judgment that this stricture is going to be refractory, and you start using this protocol right away. And this is the study by Bell coming out in GIE that I was asked to write an editorial on. They could predict at index endoscopy that the stricture is going to be refractory, and in those cases, if we use this protocol upfront, our success rate reaches 83%. So mind you, these are patients who are potentially failed dilations type of patients. Now, this is the region where we still have a problem, roughly around about 15% of these patients. We need to figure out what's happening. So in our patient, we put a stent in, we took the stent out, the stricture remolded like this. He still required 1 dilation every 10 to 12 weeks. Initially, he accepted 4 to 5 dilations per year, then got frustrated, refused surgery. What next? So we have now started this in a very aggressive manner. We have a clinic called the self-dilation clinic. This is that patient. He has given me permission to record him. We don't have sound over here, but actually in my presentation there is sound. We make the patient sit in front of a fluoroscopy monitor while he is placing the self-dilation down. He is watching the screen as a biofeedback. We encourage him not to hold his breath, continue breathing, and also swallow. And this is our speech pathologist over here, Jennifer, encouraging the patient to take the dilator down, and then we switch the fluoro off and ask him to do that again. It is just 15 minutes of training. That's it. And now he's doing it without fluoro. And 3 months later, I got him back to record him again, and you can see he's been dilating himself. He knows to take it, and look at the amount of weight he put on. So self-dilation is an underutilized system. Now, even with head and neck cancer, where the stricture is very high, and we have people with even tracheostomy, those also do very well with self-dilation. For example, this is one of my patients who has got a tracheostomy. Laryngectomy was done on this patient, head and neck cancer, very tight stricture in the hypopharynx. And he's got an even larger diameter that he's dilating himself every day, twice daily. So this is another, situation where I try to introduce self-dilation in these patients sooner than later, not as the last alternative. We, as I said, have a now self-dilation clinic. Now, problem with self-dilation becomes this: when you have a diverticulum or you have a ledge, they put the dilator down and you see how it curls. So in these patients, we came up with an idea which, as I said, is coming out in press, how to even deal with these kind of situations. So what we do in these patients is that we can needle knife this ledge, or we don't have to, put in a stent, take the stent out. This is the same patient, by the way, and look at this area, how it opened up. Now you made it straight. In the morning when we pull the stent out, the same afternoon we made this patient do self-dilation. And what we did is that we bought the patient a self-dilator which is smooth but blunt. Because if you take the traditional bougies, the tip of this can hit the opposite wall of the stomach and the patient will find resistance. But if you take this self-dilator, it can go down across this area. Now, self-dilation is not new. One case in 61, another 3 cases in 1961, 13 patients with a total of 4,600 self-home dilations in 1984, and it's a relatively recent study, up to 60 French. You know what is unique in all these studies? Success rate very high and no perforation. Why? You can't perforate yourself. I can perforate if you're under propofol. But you dilate and you have that discomfort, you'll stop. And with this approach, in that particular case of mine that I showed you, we reached 100%. Now, last few slides, and I'll wrap it up because I think I may be running over our time. Now, what happens when we dilate these patients, or we put a stent and we pull it out, or we use electrocautery incision? These are the strictures. You cause epithelial damage, a lot of mucosal injury, and the healing process takes you back to the stricture. And when you have this, you're basically going in circles. You're dilating, you're causing mucosal damage, and this heals with a stricture. Currently, our focus is mostly on this area, from dilations to cauteries to stenting, but we are forgetting this part of the equation. Why this is important? If you look at mucosal injury, fibrosis develops in 2 weeks, and epithelial cells from the sides come, and the reepithelialization takes up to 5 weeks. By that time, the lumen has already distorted. So in this particular case, there is nice healing. And you biopsy this, it will be squamous epithelium, but the lumen has already gone stenosed. That is because fibrosis sets in 2 weeks and epithelium takes 5 weeks. One way to overcome this is to inject steroids and delay fibrosis, and the results have been mixed. But how about hastening epithelialization? What if I can make that area epithelize in 24 hours? Or put a new epithelium immediately after I dilate the patient? Will it make a difference? A lot of regenerative medicine work is going on in this area. Autologous pluripotent cells are being injected at the site. They take the adipose tissue, suspend it into buffer or buccal keratinocytes after dilation, inject it, or they can grow the epithelial cells into cell sheets and apply it. This not only is for strictures, but also for circumferential ESDs. This is self-assembly peptides. We talked about that this morning, that we can use, and these self-assembly peptides, they come in a liquid form. Purastat, you heard about the Purastat this morning. People have been using it for bleeding, but you can actually spray it after mucosal resection. The peptides are randomly, nanoparticles are randomly present in the fluid. When they touch tissue, they align and they form a carpet. And that's how you'll find that if you dilate and spray it with Purastat, will it make a difference? Or we can grow the esophagus. So there are a lot of these regenerative medicines coming up. So at the end, in summary, what is new? Set the goals. When you have these patients, ask what they want. A soft diet, they want to eat regular diet, and tailor whether you want to achieve 14 millimeters and go higher, or what is appropriate for that patient. So it's not always essential that you need to go at this level and put the patient at risk of perforation. Preferably start off with weekly dilations and then adjust as per response, and go back to weekly dilations with larger dilators after you apply other interventions. So if somebody comes with 2 millimeters diameter, to take that patient to 14 millimeters dilating every week will take you about 5-6 weeks. But what if you put an 18 millimeter stent that will stretch it, and in about 1 week you'll go from 2 millimeters to 18 millimeters. And then when you pull the stent out, now you have an 18 millimeter lumen. Start dilation every week. But even better, start dilation every day, maybe 2 times a day, and that is where self-dilation comes in. So a lot of my patients, when I have them with a lumen of 8-9 millimeters, I put in a stent, maybe gently dilate it a little bit so that when the stent expands, it doesn't hurt. The stricture is now stretched to 18 millimeters, and the patient is immediately told to do self-dilation. And instead of dilating every week, he's dilating every day, he or she. So that is where consider self-dilation before recommending surgery, but as an additional thought, actually use self-dilation sooner than using it at the end of the game. Start using stent, at least in some cases, to dilate from a small diameter to a bigger diameter rather than 18 or 11 dilations. Consider dilating slowly with a stent and go to self-dilation. And then last but not the least, we have now tissue matrices in our surgeons, whenever they do gastric pull-up and they anastomose the stomach conduit to the remnant esophagus, they cover it with a placental membrane that is available in the market nowadays. And that has also shown to be, reducing the leaks that can happen with anastomosis. What about using it immediately after dilation? Thank you.